So hey everybody, just welcome to another Residency VMR episode. And today we are delighted to have the Cleveland Clinic Internal Medicine program and the case presenter here, and a very old friend of mine is Francisco. I remember that the first time that I was introduced to the clinical problem solvers, the amazing community. Francisco was there, like teaching me how to organize and present the cases, and well, that was many years ago, and it's great to have you here presenting, Francisco. Yeah, how have you been?
Hi, Vinny. Thank you so much. This is always an honor to be here. Clinical problem solvers has been a big part of my journey through medicine, through the US. And yeah, I'm very glad to see so many friends here and also people joining from the program. So I'd like to thank both the Cleveland Clinic, the program that's training me, and also the clinical problem solvers for doing this. We'll have a lot of fun, and at the end we'll have a quick Q&A, and you guys will be able to ask any questions and learn more about the program.
Yeah, well, thank you, and absolutely. And I also have here Dr. Kaiser Kensam, who's a chief in the program. Hey, Dr. Kensam, can you present yourself, please? Introduce yourself.
Yes, absolutely. Thank you so much for having us here. And Francisco, we're also proud of him for, he did a great job last year and again this year. So we're happy to be here for him and to support him. Um, I myself am a big fan of your podcast. We use your illness scripts and diagnostic schemas all the time during our clinical reasoning conferences. My name is Kanza Kesser. I'm an associate program director and a co-director of the hospital medicine track, along with Aiden Newstattle, who's also on the call. And both of us also run the clinical reasoning conferences for our program. I'm originally from Pakistan, where I went to med school, and I completed my residency training actually at Cleveland Clinic. And I loved it so much that I decided to stay on here as staff as well. Um, yeah.
Well, that's wonderful, and sorry for, I do apologize for introducing you wrongly.
No
I
problem at
know,
all.
but we can go. It's okay. So we also have here from the program Max, Aid, and can you guys introduce yourself, please?
Yeah, thank you guys so much for having me here. I echo everything Dr. Kaiser said. We're so proud of Francisco. I don't know where he finds all these cases. I need to start hanging around with him more in the hospital, all these interesting cases. But I'm one of the chief medical residents here. I'm finishing up the second half of my year before I'll be pursuing cardiology fellowship starting in July.
Awesome, and Aiden.
Hi, everyone. I'm Aiden Newstattle. Sorry, I can't figure out how to get my camera working here. But I'm also one of the APDs, similar to Dr. Kaiser. I'm one of the co-directors of our hospital medicine tract, and then we work together on our clinical reasoning conferences. And so we definitely, like she said, we steal a lot of your guys' illness scripts and diagnostic schemas when we're going through cases. And we're just very fortunate to have residents like Francisco who are really engaged and help bring us cases like this to be able to talk about.
Awesome, yeah, and I do want to take a moment to thank the people that is helping this session to make it possible. So Glenn is responsible for doing teaching points. Julia is scribing, and Rahul, David, and Ravi will be discussing the case. And without further time, we can share the screen and start the case presentation when you're ready. Julia, yeah, go ahead, Francisco.
Sure, no, thank you all so much. So we'll start as usual. Quick one-liner. 49-year-old male patient presenting with 2 days of suspicion of painless rectal bleeding.
Davi or Rahul, do you want to tackle the first LQuad?
Hi, friends. Thank you so much, Francisco, and the rest of your team, for bringing the case. So, yeah, first thought that comes to mind here, when we have a patient bleeding is, does this patient need management and stabilization before diagnosing? So my first thoughts here would be, first, is this patient hemodynamically stable? Second, is this patient on any anticoagulant or antiplatelet agent that could need potentially to reverse? Second, is there third, is there any source of bleeding that I can address just initially? And then what other treatments do I need to start? Does this patient need, for example, to start a massive transfusion protocol or something like that? The fact that this is 2 days and seems to be presenting with rectal bleeding, is not may not be so alarming, but I think we have to keep in mind that rectal bleeding can be also a way of manifestation of upper GI bleeding. So not only lower GI bleeding can present with rectal bleeding, but brisk bleeding in the upper GI sources can present with rectal bleeding. So my first thought would be, that is this patient does this patient have any history or any signs in the initial evaluation of cirrhosis? Because if that's the case, I maybe maybe be more concerned than likely cold GI in a fewer time than in other instances. Aside from that, the rectal bleeding, as I was saying, can be very brisk upper GI, but more commonly is lower GI bleeding. And in those instances, like the possibilities are many, but the main things I think we usually keep in mind are diverticular bleedings, structural bleedings that like structural lesions in the colon or the last parts of the small bowel that can also bleed, and any kind of anomaly in the vascular system, such as angiodysplasias that are common in patients with in more older patients than this one. But yeah, I think, well, the possibilities are many, but first thing, is this patient, and does this patient needs to stabilize? And the other thing I wanted to mention is, with this framework, I'll think that maybe this is a local problem, but we have to keep in mind also the possibilities of this being just one bleeding in a patient with a bleeding diathesis. Like, I would want to ask if this patient had any bleeding through other sites, or any ecchymosis, any signs that could point more toward a systemic problem. But yeah, Raul, do you have anything else to add, or any correction?
Yeah, thank you, David. Yeah, you clearly lay down the foundation and how to approach this patient in real time. First of all, thank you, Francisco, and the clinic team, and from presenting the case today. I think this is one of the most common bread and butter ED visit, the chief concern. As David alluded, the management is more important than the understanding the root cause. As David said, I just want to quickly look at the vitals and see if the patient is hemodynamically stable or not. And And one more thing, given the age, I have seen a lot of patients coming with this kind of complaint above 60, 65. My reflex thought process, hey, is it something related to diverticular bleeding? But given the age of 49, the prevalence and incidence of the diverticular pathologies are less likely. But that does not rule out that does not rule out the diverticular bleeding. So to understand more, I just want to know, who is this individual? Is this patient chronically constipated that is causing the intraluminal pressure leading to the diverticular bleeding? So understanding more as an individual and understanding what are the risk factors this patient has in terms of, as David mentioned, what medication the patient is on, any blood thinners, any antiplatelet agents, something I'm interested into. And given the very acute onset of presentation, we cannot rule out and painless rectal bleeding. And I just want to know what exactly happened rather than just taking the medical word. The pain, I just want to know, is this any kind of blood mixed with water, any blood mixed with mucus or pus? That gives me an idea. Is this an acute infectious and inflammatory process? So maybe I can ask, hey, what did you eat? Did you eat something new? Did you eat any kind of unprocessed food, meat, pork, and all these things? Because this is the most common base rate. And yeah, and those are my thoughts. Back to you, Francisco.
Great differential diagnosis. Now I'll answer exactly the questions that you are laying out. And the problem representation will change also a little bit, which was interesting. So over the preceding 2 days, the patient reported marked hyperphagia. During these 2 days, he consumed 3 full pizzas, 2 whole chickens. He became concerned by noticing these red-tinged diarrhea, and therefore he presented to the emergency department. He denied any previous episodes, other sources of bleeding, ecchymosis, abdominal pain, weight loss, fever, chills, arthralgias, rash, or other weakness in general. Further history revealed that he had been incarcerated for 23 years and was released 3 years prior. He had been in a Supermax security prison in Arizona and is originally from Ohio. So following his release, on his way from Arizona to Ohio, he started complaining of episodes of chest pain, dyspnea, and syncope, all exertional. On his way here, he stopped in Iowa, and the doctor there that he told him for unclear reasons that he had a weak heart. That's all we know. And he didn't pursue any other follow-ups. He denied doing illicit drugs during incarceration. However, when he left the prison right after, he started consuming intravenous amphetamines only after his release. That's what he told us. He also reported regular marijuana use and heavy alcohol consumption. In terms of past medical history, we have testicular cancer, and his epididymis was removed and treated hepatitis C. In terms of medications, he's not taking anything. Also, no allergies. And in terms of family history, doesn't have connection to his family, but he denies any relevant family history. I think we can stop here.
Yeah, thank you so much, Francisco, for such a rich eloquent here. I just want to confirm that that I understood it right. That patient had he ate something and notices a red tinge diarrhea from the last 2 days. From the following the prison, he has been having a lot of cardiovascular symptoms, and now he has been told that he has a weak heart. Am I right?
Yeah. So this is for these past 3 years. Yeah. But what really made him concerned was this rectal bleeding.
Okay. Thank you. And maybe I can dive more into the HPI, and maybe David can walk through about the significant past medical and other histories here. I mean, yeah, I mean, at least we know that he ate something that could be of because that is a more acute concerning thing. Um, he ate something, and there is a kind of he's a vulnerable host. Maybe I can think of all kind of infectious process. The one that comes to mind is something to do with the Escherichia coli, E. coli, O157 H7 strains, or Shigella, or Campylobacter. I don't think Salmonella is more prevalent here, Salmonella typhi, but there are other Salmonellas, but it rarely causes the bloody diarrhea picture. And those are the bacterial organisms I can think of right now. And yeah, so that would be my understanding of the diarrhea part. Now, it's really interesting that he has been having this exertional, all the cardiovascular symptoms from the last 3 years. um okay, so maybe I have, before diving into what's going on, maybe I have to understand the more problem a little bit. Is this something to do with the if I look at the heart, is it something to do with the pericardial problem, or myocardium, or endocardial problem? Given we know that this patient uses an IV substance use, that puts him at very risk for endocarditis. Is there any kind of valve pathology or endocardial pathology causing the all the valvular insufficiency, leading to the cardiovascular compromise? Is it something to consider? And is there any kind of stenotic pathology, like for example, one of the most common feature of aortic stenosis, more common in elderly individuals, is syncope, but 49 less likely with the tricuspid aortic valve? Maybe the patient could have any bicuspid aortic valve pathology, and all these things we can only visualize through echocardiogram. So my threshold for getting an echocardiogram for this patient is very low. I'm going to get that. and and also, we are done with the pericardium, myocardium, and endocardium, as well as the valves. Okay, and all these things is causing the hemodynamic compromise, leading to the decreased blood flow to the brain by decreasing the perfusion, causing syncope. So that is one approach of looking at this stuff. And the second thing is, it's completely different pathology sitting in the lungs. And we know that the patient is using marijuana, and because something marijuana also causes all the vaping, marijuana, I think it's called, the way how we takes the marijuana, it can cause different pathologies again. Maybe it's something to do with the maybe that kind of lung injury, or given the patient coming from the prison, there's all kind of infections we have to consider, definitely TB. And given the patient is in Arizona, I have to consider all the indolent organisms like histoplasma, blastococci, and all these things can cause the pulmonary compromise too. Now, between all these things to what I'm gonna, and patient is telling that, indirectly telling us it has weak heart, but we have to understand what exactly is weak heart is. Now at the moment, I want to focus more on the heart over the chest, but definitely we are gonna get the pursue the imaging, at least CT chest, to delineate is there any kind of infiltrates or opacities in the lung parenchyma. Yeah, so those are my thoughts. David, what do you think?
Thank you, Raul. Yeah, I don't know. Um, I don't know, really, what's the problem for now, because, um, the first, set of information that we received is painless rectal bleeding, and apparently later patient, what we recall is that the patient had, red team diarrhea. I don't know if that is blood or not. So my first thought would be, yeah, would try to clarify that, and do possibly a digital rectal exam to clarify that that's blood, that what are we seeing, or maybe even show patients some pictures to try to differentiate between both. And I think this patient had like a very rich background that could point towards many things, like likely heart failure, or as you said, possibly aortic stenosis in the background that make you think of Hayes syndrome, but this is usually in older patients. The incarceration history may make you think of TB and other even other infections. Their drug history like may may clue you into, for example, ischemic colitis, as was also mentioned in the chat. I would be curious also if this patient had any sexual risk behaviors, given the possibility of rectal bleeding, although proctitis is usually more painful. But my first thought here would be trying to clarify what is the problem that we're trying to solve, because I think there is like a lot of noise in the background and not very clarity in the foreground. So yeah, let's see what the exam tells us, and let's see the labs if there's any concern for bleeding, and later we try to merge all together. And just a comment, I don't know, it's like unusual to, I don't know if anyone has told me, like, or I have framed a problem as hyperphagia. I don't know if this is really a symptom of the patient, or is just something that we have like just created and assessed like that. But if that's the case, I think like very few things come to mind. Mainly some endocrinopathies, and maybe also some drug or substance effects, marijuana between them. But yeah, would want to make things clearer, and let's see, Francisco.
Yeah, no, very good. I can tell you guys are both very experienced discussants, and I think the hyperphagia is also subjective. I was just so impressed when he told me what he had eaten these last 2 days. Then I agree. I think the difficult part here is really framing the problem, and you guys were asking questions that I'm going to answer right in these next aliquots. So if I'm allowed, I'll share my screen. So if you allow me, I will do it. I think I can.
Yeah, you can.
Okay. Can you see my screen? So we'll start with the EKG. This is what we see. You know, I'll try to be faithful to the timeline of events and how this happened. During my ED rotation, I was seeing this patient, and I noticed this EKG. Not sure if you guys want to just say a brief comment on it. Raul, David.
I think David is an EKG expert in the clinical problem solvers. But before David gives his pulse, maybe I can try, and David will correct my knowledge gaps here. I can see. Let me go with the basics here. Is that what exactly is the rate? I can see almost around kind of 90, heart rate around 90. On P wave, I can see a P wave. On QRS and T wave, I think the rhythm is regular. From the axis standpoint, as the right axis, I can see the right axis deviation, and I can see a T wave inversions. That is the most concerning thing in the V3 and V2, and maybe something suggestive of some right ventricular strain until proven otherwise. And ST changes, maybe is mild, but not in the range of STEMI. but definitely I'm gonna get a troponins. I cannot rely on my EKG skills. And
Perfect. No, that's just perfect, Rahul. Not sure if David wants to add something, but I think that's absolutely right, what you just said. Then I can show you the vitals. This is what the patient's vitals quite unremarkable. And then I can show you the X-ray. Any comments on the X-ray? Otherwise.
Yeah, I think I don't see clearly any laryngeal opacities. And I don't think there's either clear cardiomegaly or if it is borderline. We don't see perfectly the costophrenic angels, but I think don't see clearly a pleural effusion. The only thing that is a little bit striking for me is that pulmonary arteries may be enlarged. I think also, yeah, maybe if I didn't see the ECG, maybe I didn't notice
Exactly.
this. But yeah, there were maybe
Yeah.
signs of right heart strain, and that may be going to the same direction. Yeah.
Yeah, no, very, very good, and you know we'll keep moving ahead. And so the patient on physical exam, he was not in acute distress. He was not having active chest pain. It was really just with exertion. He was laying comfortably in bed. He was well appearing, normal heart rate, rhythm, no murmurs, no wheezing or rales, abdomen flat, non-tender, non-distended, normal capillary refill, no focal neurological deficits. Uh, DRE was also unremarkable for any masses or gross blood, and the occult blood test was also negative. That was something I wanted to reinforce. Then his blood work was also unremarkable, and we have an hemoglobin of 16. We have a white count of 8.8, platelets of 259. I'm just saying the most important. Then protein 7.7, calcium 9.3. All the liver enzymes were normal, AST below 20. We have a normal creatinine 0.95 with a BUN of 16, sodium 137, potassium 4.7. The bicarb was 21. PTINR also normal, within normal range. D-dimer, and of course some of these came a little bit later, 220. The troponin trend was the following: 9, 10, 9. And the anti-proBNP was elevated at 2200. Eventually, we also got some autoimmune markers that were negative later on. And so overall, everything looked within normal limits, apart from the BNP. And I think before I move to some more imaging studies, I think we can stop here and go ahead. Go ahead, Raul, David.
Okay, I can go. Yeah, I think there's kind of a disconnect between the chief concern and the the rest of the picture. These may be some of these instances in which patient is coming to a hospital for whatever reason, and we are not so interested in whatever is the reason of the patient, but what we find in some imaging or whatever. And one question here would be if this needs like what kind of treatment or investigation does this need, like in hospital or not. But going into what I think here is that we're the exam doesn't have anything pretty remarkable, and what is most remarkable of the ECG chest X-rays the possibility of pulmonary hypertension, and yeah, the labs could be in that direction too. I would, yeah, first thing I could do here likely is try to do some focus, or maybe call the cardiologist, but I think likely do some focus here first, and try to know if that hypothesis is well directed or not. And regarding that hypothesis, one possibility would be, is this patient having pulmonary hypertension secondary to the amphetamine use he has had in the past? Because I don't see any other aspect in the history or the drugs that he's taken that could explain this. Yeah, I think we will likely need also maybe better imaging of the chest to assess this, and also try to interrogate the patient if he's having some dyspnea on exertion. This seems to be, I don't know if that was stable for the last 3 years, or if that's not the case. Trying also to know if this problem needs like an urgent care or not. And just one comment I also wanted to do is that for me in the EKG, yeah, maybe there were signs of right heart strain, but another thing that I think was a little bit unusual is that the like the R wave progression up to B6 like wasn't present, like DS was higher than DR, um, even in V6. So I don't know if this would be just limited to the RV, or if there's any involvement of the LV, and I think, yeah, that could be also the case. But yeah, many things to clarify more. Raul, what do you think?
Your wonderful thoughts, David. Francisco, I have one question. I see that he has a testicular cancer and epididymitis was removed. And do you know any other pertinent history regarding that? Is there any radiotherapy or what kind of intervention was done and when was it done?
Very unclear. It was right at the start of his stay in the prison, and he did have both testicles. I can't really remember if he had any other intervention. So probably might have not even been cancer. So
Okay.
that's what I said.
I think it's kind of unclear. All right, that's fine. All right, because I think there are a lot of confusion, and as David mentioned, there's a lot of noise here. Maybe I can do a quick summary to understand what problem we are trying to solve here, and I can give my own individual thoughts. So here we have a 49-year-old male with past medical history of treated Hep C with unclear testicular pathologies, questionable cancer, presenting to the ED because of the acute onset of diarrhea versus painless rectal bleeding, but found to have chronic history of exertional chest pain, dyspnea, and syncope, and with risk factors including the substance use, um, with vitals suggestive of mild hypotension, with EKG findings suggestive of right ventricular strain with elevated D dimers, and pro BNP likely suggestive of any cardiac stress. So that would be my problem presentation. Now, as David mentioned, the reason why he came to the hospital is because of the painless rectal bleeding. that we were initially considering the GI bleed, hey, is this angiodysplasia or something diverticular bleed? But often the patients present problem in different way, and we analyze the problem in a very objective metrics. The what I'm trying to say is, when we get the hemoglobin of 16, maybe the patient is kind of dehydrated. So what I'm going to do, definitely in the ER, I'm going to give a bunch of fluids. And for example, the patient is in cardiac overload, I'm going to be more cautious, but maybe I can do an IVC or to see maybe if there is any room for fluids. I'm going to do that. And the second thing, maybe I can assess him HNH probably after 1 and 2 hours to understand, because whenever there is an acute bleed, body takes some time to restabilize the fluid shift, and then you have to take that hemoglobin as an accurate marker rather than hemoglobin of 16. So that is kind of, it's not a kind of nightmare for me. I don't have to call the GI in the midnight whenever I'm seeing this patient. And then the second thing is, I don't see any kind of electrode abnormalities. And Rabi always taught us that if you don't see any problem, if you're not able to make any progress with your physical examination findings, with your basic labs, then the next modality of choice would be the focused imaging. Here, though, we have a lot of noise around the cardiovascular system, the lung system, but we don't I'm not hearing any murmur, I'm not seeing any crackles, there is no signs of respiratory distress, nothing. I cannot in ideal world, I really don't know how to treat this problem, but I have few objective criteria to triage these patients appropriately to the ICU or step down or telemetry. The reason being, we have EKG signs which are really really concerning, and either David mentioned it could be pulmonary hypertension slash or pulmonary embolism until proven otherwise. And the second thing would be uh, getting in focus to understand, is there any kind of tricuspid valve regurgitation. The reason again is, given the IV substance use, there's a high chance of causing the IV substance use that travel through the venous system, go into the IVC, or and then they drain into the right ventricle. So the tricuspid valve is something which is most commonly affected with IV substance use. That is number two. And though the echocardiogram, transthoracic echo, is not a good indicate, we cannot visualize the tricuspid valve better than any other valves, but something to consider in the beginning. And the third thing is, I wanna, because his kidney function is really good, the threshold for getting a CTPE a protocol to rule out the pulmonary embolism is the ideal step. It would be reasonable to rule out that, because that really guides the management. Whether we have, though there is no hemodynamic compromise, I really don't have to do any catheter based thrombolysis and everything else. But who knows, the patient would crash soon, but we have to do the rule out pulmonary embolism in this patient. And what are the next things? Now, uh, we are gonna I'm gonna do this thing, and yeah, I think I have to juggle between the management and understanding the more problem in a detailed way. And once I'm gonna even though I'm gonna get the kind of lung parenchymal findings in CTP, I think the CT chest without contrast would be the good thing to visualize any kind of lung opacities or okay, those kind of stuff. Once I understand this problem, then what I'm going to do is, I'm going to pursue whether this patient needs advanced imaging or not, because there is a question of testicular cancer which is unclear for us. Maybe the patient has some kind of retroperitoneal lymphadenopathy. I'm just trying to speculate here to understand my patient better. And yeah, again, though there is no kind of fever, but the risk of endocarditis slash or all these things are very high. I don't know the utility of getting a blood cultures at the moment, but something I'm gonna consider the back pocket. Yeah, very very interesting case, Francisco. Back.
Very good, Raul and David. And I think this illustrates this case illustrates the two things you were mentioning. First, understanding what's noise and what's real, and then balancing really, okay, making progress in the diagnosis, but also being mindful of the management. Those are also very good teaching points that you guys put out. Then as always, you asked for focus and you asked for CTPE, so you'll get both. one thing that I would like to highlight is that besides clinical reasoning, our program has been very invested in also developing the POCUS curriculum, and that's one of my also particular interests. So I will share. It's not, of course, the best, the most quality POCUS, but this is what I could get. So I hope you can probably make some comments on on these apical view. What do you guys see? Right ventricle, left ventricle, atrium. Who wants to make a quick comment?
David, again, David is the POCUS and the EKG master in the CPC. So I think I'm not gonna do justice. So I think David would be the ideal person.
No way, Master, but yeah, we see here actually dilated RV that is also pressing like the LV has an overload over the RV, the septal in the interventricular septal is deviating, and we see also a pretty enlarged right atria. We didn't see clearly the like the free wall of the right ventricle, but the contractility of the right ventricle yeah diminished. Like I think probably RV dysfunction also. But yeah, no view, 1B is no view. So let's see more.
Yeah. And then we can take a look at here at the CTP. Also, the CT abdomen and pelvis was unremarkable. It didn't really show. We also did with contrast. No active extravasation in the rectum, no masses, and the patient indeed he did have one bowel movement in the ED, and it was formed stools. No obvious bleeding there. So I also wanted to leave that information there that we did see it. So we can. I think I picked this view because it's the most informative. What do you guys think about this particular view where you're seeing here the RV right near the sternum and also the pulmonary arteries here?
David, maybe you can correct me if I'm wrong. I don't see at least any filling defect. And then I don't know what exactly is this coming from the RV. It's a kind of very, I think it's a kind of dilated RV, which is because it's very close to the sternum, but it's kind of very dilated and the enlarged pulmonary artery too. Maybe those are the things we are seeing on the chest X-ray. And I can see as the, I don't know if it's right, on the to the iota I can see kind of constriction, and I don't know, I really don't know, but there is some kind of you can stop there. Yeah, there is some kind of inside iota. I don't know what it, I really don't want to use wrong names here, but something wrong. Maybe I can ask my radiologist, hey, what is this, something like that. And then yeah, maybe you can give me the official findings after the David makes his comments.
Yeah, I think this is not usually the projection. I think that I use like I've seen that it is used to measure the right pulmonary artery, but looks like pretty large. So yeah, I don't see clearly any other finding except from the dilated RV.
Yeah.
But yeah, I think
Yeah.
yeah.
That's basically it. I pick also these views on the POCUS and on the CT for time's sake, but we also the RV can be very trabeculated, but we did see some trabeculations here in the dilated pulmonary artery. So yeah, that's mainly what I wanted to achieve. No feeling defects. The CT of the abdomen and pelvis was also normal, and it was actually the POCUS that convinced the cardiology to stop by and admit the patient. And then the next day they got a PET stress that was negative and an echo, a formal echo by someone very experienced, of course. Showed an LVEF of 62%. The right ventricle was severely dilated. RVS, right ventricular systolic function, was moderate to severely decreased. And for some reason, I forgot to put here the RVSP, but it was elevated, I think above 35. I forgot to do that. So that's it. I have one more thing to show, which is as expected, the right heart cath. But I'm not sure if you want to make some comments. But you are already, I think your reads of all these 4 imaging studies, tests, were very accurate.
David, it's your turn or my turn? I forgot. That's fine.
Never mind. Well, I think so. This is likely chronic pulmonary hypertension. And trying to think a little bit, I think type 2, which is the most common group of pulmonary hypertension, is less likely here given the well, the LV function seems to be normal, but we don't see we haven't heard anything about any valvulopathies. I don't know if the diastolic function was also measured, but I think yeah, apparently nothing very remarkable there. The group 3, we don't have like Francisco didn't tell us anything about the lung parenchyma in the CTP. It's not the bear test, but yeah, if there would be anything very abnormal there, Francisco would have told us. We can do, I think, PFTs likely in this patient, just to exclude any possibility of obstructive lung pathologies that could also make a little bit, at least make a contribution into this pulmonary hypertension. We don't have also any history of OSA or something similar, but would like to at least ask the patient if there's any symptoms regarding that. Group 4, the CTP was apparently normal or without any pulmonary embolism or obstruction in the pulmonary arteries. Group 5 is a mixed thing, so I wouldn't go into that. And group 1 is what I think maybe is more likely here, given also the age of the patient. And would like to first do an HIV test here, although I think the amphetamine use is like the most possible culprit here in the history. The autoimmune serologies have been negative, I think, and we don't have any travel history also to think in schistosomiasis or something rare. In CPS, there we love, like, I I haven't seen, I think, a case, but I probably missed many of scurvy, and we have seen scurvy in some instances causing pulmonary hypertension. And maybe this patient is a little bit at risk of scurvy given his past medical history, and would like to do a thorough skin exam to exclude that. And yeah, there are many other possibilities in the type 1, including and genetic ones. But yeah, for the moment, the drug history is seems to be the most impactful here. But let's see the cath before.
Yeah, maybe wonderful thoughts, David. I mean, honestly, I don't have much to add. I'm just processing how to categorize into different buckets, and you clearly mentioned that. And maybe I can share something which I learned recently from Kirtan, that sometimes though the CAT scan, the CTP does not show pulmonary embolism, but there's an entity called tumor microangiopathic process. So what happens is that all these tumor cells, maybe the disseminated one or the local process, they're gonna slowly travel across the minute pulmonary capillaries, which are never captured on CT pulmonary protocol. And all these things would cause the arterialization, the same pathology of pulmonary hypertension, leading to the right ventricular strain. So once we exhausted, of course, we know there's a kind of very culprit agents here which could possibly cause pulmonary hypertension. But definitely, I really want to make sure that I'm not missing any kind of malignancy. Maybe I can go to the bedside and ask the patient, hey, any weight loss, any unintentional weight loss, any night sweats, any lymphadenopathy, all B cell symptoms, just to be clear that I'm not dealing with any malignancy process. And and that I learned that the definitive management or the diagnosis in pursuing that diagnosis is lung biopsy, where you can see all those tumor cells under the microscope. But why my threshold is not high, but something I also consider. And then, as you mentioned, class 2 is less likely. Class 3, maybe you can definitely consider pulmonary function test. I really don't know the BMI here, but obesity hyperventilation syndrome or obstructive OHS, OSA, there are some kind of risk contributing risk factors to the pulmonary hypertension. And class 4, less likely, unless a until patient has some kind of this tumor microangiopathic process which are traveling across the capillaries. Yeah, and right heart cath, it's gonna tell us is it precapillary and all those anatomy. And yeah, those are. And one more thing is to make sure, which is something I learned in NEJM recently, that there is an entity called pulmonary veno occlusive disease. It's kind of pulmonary capillary angiomatosis process, where we have to be very cautious in treating with conventional pulmonary hypertension medications. But anyways, I'm going to have very good backup from the cardiology and pulmonology to guide me what I should do in real time. Back to you, Francisco.
Very, very good. So as expected, here we will get the right heart cath. That, as you can see, mean PA pressure 26, very elevated, with a very surprisingly low cardiac index. It's below 2.2, right? And otherwise, the RV, at least the pressures were decently. If you calculate the PAPI, the systolic minus diastolic divided by the RA pressure. So that's pretty much it. I don't have here the PVR. For some reason, PVR was more than 2. And the patient, when he was in the cardiology service, they started him on sildenafil, and unfortunately, he couldn't be started on the IV medications because of his history of IV drug use. And the patient ends up being discharged with close follow-up. Even before he left, he had genetic testing. And actually, the results got back actually this week. It was interesting, and there was a variant of unknown significance of a gene the SCN5A, which is the gene involved in Brugada syndrome. And unfortunately, he was arrested again, and he hasn't followed up. I think I saw this patient late last year, so he hasn't had a proper follow-up. What do you guys say about the final diagnosis here?
Maybe, I mean, given the elevated pulmonary artery pressures, I would say uh, the severe pulmonary, I really don't know the gradings of it, but I would say severe pulmonary hypertension with right ventricular right ventricular failure, something like that. Secondary to this questionable genetic testing. I mean, yeah, it's not a questionable thing anymore. Yeah,
It is, yeah, it's unknown significance. So the drugs indeed might
yeah,
have played a good role.
yeah. So yeah, what do you think, David?
I think, yeah, I think maybe the drugs are the culprit here, like the IV amphetamine, is as Lyra was mentioning in the chat, is incredible, like how young patients are able to compensate these severe like manifestations. And it's true that that from the beginning the history of exertional chest pain, dyspnea, syncope, like is very worrisome. Like
Yeah.
is a good is a good it's a good thing to catch, like like you any of us could have seen this patient in the ER and say, well, the diarrhea seems not to be a lot. There seems not to be rectal bleeding for now. The hemoglobin is fine. Patient is hemodynamically stable. Like you maybe don't have anything else to manage further, but yeah, the simple tests like the ECG and going a little bit further into the history, like made the possibility of diagnosing a severe disease and that needs likely treatment, because like the yeah, the prognosis for this patient, if this is not treated, is not good, and this patient is a very young patient. So yeah, careful attention to the details, and a simple test as the ECG, I think, help make a lot of progress. Yeah.
Yeah, yeah. It was really the EKG and then the POCUS was extremely helpful. I think that case really highlights also trying to differentiate the noise from what matters. Also, always thinking about the management, as you were very well highlighting. And then I think the problem representation in the middle of in the middle of the presentation that Raul did, it was marvelous, and it's something that I always try to do myself, and following the examples of Ravi and Rabi, and I encourage also my interns. And interestingly, the one that said first in the chat, amphetamines inducing pulmonary hypertension, I think is the only first-year resident of the Cleveland Clinic that's here, Cesar. I swear I didn't share the case with him, but he after he saw, I think, the EKG and the X-ray, immediately said amphetamines causing pulmonary hypertension. So very well said, Cesar. And then I think the last teaching point and is really the social determinants of health. The guy unfortunately left the prison, and that's when he starts using drugs that might have caused this pulmonary hypertension, and then he ends up being arrested again, no social support, and the current prison system being more punitive than really leading to rehabilitation, like what happens at least in my home country, Portugal, focusing more on rehabilitation and not just being punitive. So the very sad case, because as I said, he was really in cardiogenic shock, right? His cardiac index was 1.6. He didn't have a lactate, but this also tells us how well he was able to compensate. So as David very well highlighted, so he needs treatment. He's not getting appropriate flow through the pulmonary arteries to the left. So not sure if you guys have any final comments before the Q&A. There was amazing discussion. I learned a lot from you, from bringing up the Kirtan's teachings. I've discussed a few cases with him while I'm here at the clinic. So he's always present.
Thank you so much, Francisco, for this rich case. I think this is the first time I'm seeing this case. I'm discussing this one of these cases, but really intriguing that how to approach, because the reason came he because of the rectal bleeding, and initially I'm trying to solve the problem of GI system. Then eventually the calculus changed, and it was wonderful, and it's a pleasure to discuss with you, David, and come back again, Francisco, and share rich cases. Looking forward to learn from you.
Yeah, thank you very much, Raul, and thank you, Francisco, and the rest of the Cleveland Clinic for coming here. And yeah, we miss you, Francisco. Come more to the to present more cases.
Yeah, well, so thank you so much for the amazing presentation and a pristine discussion, Rahul and David. And now I want to transit the session to the Q&A session. So I'll first ask some questions for Francisco and Max, and then pass the word and Mike to the APDs present here today. So, such on general perspective, like Max, would you be able to and comfortable to discuss to tell a little bit about the program, like the size of the class and the tracks and so on. And for Francisco afterwards, I would like for you to comment a little bit more about your, as you said, the focus and your personal interest, what made you more interested about it, and how specifically is developed this main track in the program. So you can go ahead, Francisco, please.
Oh, I'm not sure if Max is here. Maybe he's answering some phone calls.
Yeah.
But yeah. I think he has his chief phone. But yeah, no, I have to say that my training here has been exceeding my expectations. I think we are in a very particular environment that sometimes is different from other institutions. One, because Cleveland Clinic, we have a lot of rare cases, autoimmune cases, cardiovascular cases, GI, second opinion, third opinions, patients that come and travel to seek care of world-renowned specialists. But on the other hand, Cleveland is unfortunately a city with a lot of poverty. I think like 30% of children live under the poverty line, and there's a lot of crime. And so we also get the bread and butter, and even extreme presentations of also the bread and butter cases. So we have the full spectrum of diseases. We have indeed the VIP patients, but also patients that are not like that, and this gives us really a good perspective of medicine overall, but also coordinating care, transitions of care. That's something that I've enjoyed a lot. And also, of course, it's we have all of those all world-renowned experts for GI, cardiology, surgery, everything really, rheumatology. But then I think our program is also being more and more committed to focus, clinical reasoning. The lectures have also had a remarkable improvement, and we always discuss cases during the lectures, always preparing us for the boards. So, and I think I can also pass the ball to Dr. Kaiser and also Dr. Neustadel, if they want to add anymore about the hospital medicine tracks, other tracks, and talk a little bit more about this.
Yeah, I think we can fill in for Max a little bit. I think he's on the phone answering some patient calls. But you had asked Vinny just kind of about size of classes and some of the tracks, and so our class sizes are about I think it's about 55 residents per year. So we're a very big program. That being said, there's a lot of ways to keep the program from feeling too big or feeling like you're just a number. So we use an X+Y curriculum, which means we do 4 weeks of inpatient service before residents get a week of their longitudinal clinic, but it breaks you into 5 groups as a resident as well. So people get really close with their individual Y weeks, their individual groups. So even though we're a big program, it starts to get narrow that way. And then we have multiple tracks that residents can apply to. So we have a VA track where residents get more time at our VA hospital, where they do mostly outpatient work there. That's where they'll have their longitudinal clinics and then get subspecialty outpatient clinics. And they spend 3 months at a time there. We have a primary care track. We have a medical education track. We have a research track that we call ClinScop, Clinical Scholars track. And then Dr. Kaiser and I are involved in the hospital medicine track. So that's what we know best. And that's for residents who are interested in hospital medicine. And all those tracks function a little bit differently, but generally it sort of just takes a small group of residents that get a little bit more focused education and different clinical experiences to sort of help prepare them for whatever their future may be.
Awesome. Yeah, perfect. And Dr. Kaiser, would you like to add something?
Well, first of all, great presentation, phenomenal presentation by Francisco. And I loved the way that David and Ravi and Rahul all approached the case. And it's always very fun to see. And just to add to what Dr. Neustadel was saying, so I think he pretty much covered the basics about the track. The clinician educator, as well as the BA track, are tracks that you match into when during the match cycle, and the rest of the tracks are ones that you apply while you're in your intern year, and then you get selected for them during your PGY2. Yeah, our hospital medicine track is the one that we can personally speak to the best. It is basically for people either interested in hospitalist careers or in heavily inpatient careers. And we focus on perioperative medicine, quality improvement, patient safety, leadership, and the operation side of medicine. I think a great strength of our program is, that we have a very big class size, but still it functions and operates like a family, and everybody is very close, and there's a lot of teamwork and collaboration.
Wow, that's wonderful. Absolutely. That's such great things to hear. And I'm curious about your, I don't know how long have you, Dr. Kaiser, have been in place as an APD, and Dr. Nostrio has been in place. But I'm curious to see about your personal perspective of how the program kind of changed and or evolved since you guys were in place.
So I do think things are constantly, changing and evolving. The integration of focus into the curriculum is something that's fairly new. I would say maybe within the past year or year and a half or something like that. There's more interest and focus on integrating AI into the curriculum as well. So in the future, I foresee that would be a big part of things as well as perhaps the informatics sides. I know is something that Dr. Bertano and the chiefs are also working on integrating into the curriculum. Dr. Neustadel, anything that you would like to add over here?
Yeah, I think those are great points. Focus is one thing that I'm very passionate about. So I always bring that up as one of the ways where our program, we were lagging behind and have quickly sort of really implemented a great program to help get our residents up to speed. I've been with the program as an educator through core faculty and now APD for 3 years, but I graduated from the program as well. So I've gotten to see over the past 6 or 7 years kind of how it's changed. And I do think one of the things that I'm always impressed with is that despite being such a large program, managing so many residents, and we really are, our residents are essential services on so many of our subspecialty services as well. So there's a lot of responsibilities for the residency program. The residency has been able to adapt to meet both resident needs and service needs from other groups in the hospital. And what I sort of mean by this is when I started as an intern, we had, I think, 4, maybe 5 services that had 24-hour calls still, and these some of these sort of like very intense call schedules, and it was a burden on the residents. We actually had issues with like work duty violations, and very quickly the program was able to eliminate those without giving gaps in patient care. So that the program is very responsive to those things, and can make changes that way to make sure that we're giving residents sort of the best educational experience without sort of causing any issues with lapses in patient care and things like that. Similarly, something that's been new in the past 3 to 4 years is a curricula blueprint. And so it's giving our residents more of a standardized set to say, hey, we want to make sure no matter what you're going into, whether it's cardiology or primary care, everybody has the same background to be the best internist they can be, and everybody's able to sort of answer those bread and butter questions and the types of things you guys talk about here. And so our curriculum has become more standardized in the past 2 to 3 years, and the curricular blueprint is something that's being tweaked each year.
Yeah, so yeah, that's wonderful. And yeah, on previous, like back in the day with private conversations with Francisco, he reinforced it and always tells about the supported environment and the level and the quality of the faculty and staff, and it's just super wonderful, great things that he always emphasized. Yeah. So Julia, please feel free to unmute and ask your question.
Hello everyone, my name is Julia, medical graduate from Brazil. Thank you everybody for being here, all Cleveland Clinic teams. And I want to know about, in terms of fellowship in the future, how does the program support in terms of like mentorship, research opportunities, if like a resident wants to do a specific fellowship in the future?
So I can comment on that. So our fellowship match rate is fantastic. I think almost every year it's close to 100%. There's lots of opportunity for research because there's specialists in every field who are writing like seminal papers in their fields that work at Cleveland Clinic, and there's no shortage of research mentors. And I think perhaps Francisco can even like speak more to the resident experience in this regard. And there's several ways most residents are able to find research mentors pretty organically, either by working with them or through referral by other residents. But there's plenty of opportunity for scholarship, and our residents do quite well on that, and they also get CME money to go attend a conference in their PGY2 and PGY3 years. Yeah, Francisco, would you be able to shed light from a resident perspective?
No, of course. No, research projects, we don't, you know, it's very easy for us to get research mentors projects. Also, we have a program that matches us with an advisor, and the advisor is someone that from day one, the first week, really meets with us and puts us in connection with other colleagues that might be having developing some research projects, and we are also getting frequently emails from the chiefs. Hey, like this pulmonologist has this idea, he's writing this paper, this review, whatever it is. Do you want to be involved? We also I have the clinical ClinScope track, and you have around 2.5 months assigned to research if you match into that track. I think around 8 to 9 residents. If you don't, you still have 2 weeks of 2 weeks of research elective that you can apply, and I've done already one of those weeks, and I'm waiting for the second one, and that really helps you a lot. So we have enough research exposure, and that really reflects on our fellowship match rate. And I think I saw a statistic that our program was the second after Mayo Clinic that published more papers in the country. So this is, of course, talking about something that goes beyond all the clinical exposure that we have already addressed, which is central also to our program.
Absolutely. So, yeah, do you want to compliment something, Dr. Nusrul?
The only thing I'll add, because everything that you guys said is exactly right, that the culture around our program always impresses me with especially the senior residents who are meeting our new interns, and an intern who says, hey, I'm interested in cardiology. A senior will almost always reach out and say, well, I'm working on this great project. Why don't you come help me with this? It's a very inclusive environment. And I think, you can sometimes hear of these stories of places where residents feel competitive with one another because ultimately they're going to be applying to the same specialties. But I think here our residents just really are very, very collaborative and always want to bring their peers on board for research projects, which can help find those projects early, get in with mentors early, and kind of make those connections early to help with fellowship down the line.
Awesome. Yeah. Well, thank you so much for taking the time and being present this morning, discussing and talking about the program. Hopefully, we'll have you guys next year. We are already excited about it, and it's so great to see you guys. Well, thank you so much for the Glenn doing teaching point to describe it, and we'll see you next year. Bye. Have a wonderful rest of your weekend.
Bye, everyone.